like to welcome you to our Lunch and Learn webinar. My name is Thomas Schiebler. I'm an instructor Education International, and I'm happy to be your host and the moderator of this live cast. Now, let me introduce you to our speaker. He is a prosthodontist, a trained microsurgeon, and a real expert in implantology. Please welcome with me Dr. Markus Beschnidt. What can we expect over the next 60 minutes from your side?
Good morning or good afternoon, wherever you are drinking tea, or even already espresso, or if it's evening in your country, you might drink something short. I'd like to welcome you. Yes, what can you expect in the next 60 minutes? Immediate implant concepts means we have a variety, and I'm only showing you one red thread through immediate treatments, how we do it in our clinic based on clinical science, of course, based on data, but also based on experience. So stepping into the comfort zone means much more that we should think not only about science, about profit. We should think about patients, people, humans. And in the actual situation as we are, we stay at home, we don't want to go out, we should look how can we make also surgery a little more comfortable. And the comfort zone in immediate implant concepts means how can we use an implant and a strategy together to make life more easy for dentists and patients. So I hope I could make you a little keen on this next 60 minutes.
Thank you for this preview. Before we start, just one more thing. If you have a question, just take your computer, type it in and send it. I will receive it here in my studio, and after the lecture, I can address it live to Dr. Beschnidt in the Q&A session. So enjoy the webinar. We will see us in about an hour.
So let me go ahead, and with immediate implant concepts, as I told you, we try to do more comfortable work for our patients. So what are the main topics in modern implant dentistry? It is more or less immediate placement of implants. We take out a tooth, we immediately place an implant. It is much more the immediate restoration or even the immediate loading, because the patients go out with provisionals or rather with teeth again. A little more sophisticated is the immediately placed and the immediately loaded implant, which means we do two things in one surgery. And finally, we also should think about placing an implant in less or even in soft bone. Before we look at clinical cases, I'd like to show you the literature on that, because very often I am asked by patients or even by colleagues, is this a reliable treatment option? Let's have a look at the literature. And I'd like to show you some literature with long-term results. Here is the first one from Testori, looking at 21 patients with in total 35 immediate implants, and 22 of them were also immediately loaded, the rest delayed loaded. And looking at 6-year survival rate, we end up with more than 95%. We have an average bone level of 0.14 millimeters, which is quite acceptable to very good. And in the delayed loading, we have the same amount of bone level. So they conclude that the long-term prognosis of these implants in fresh extraction sockets is not negatively influenced. Next study from Cohen and co-workers. They had more patients and they did everything. In 1,688 implants, they did immediately placed, early placed and delayed placed implants, and they also did in all these implants immediate loading, early loading, and delayed loading. So you have the full variety, and looking at the literature, you can see over the time of almost 9 years, we also have more than 95% of survival. The bone level, 2 millimeters, which is as well acceptable. There was no significance between all these groups, which means if you do it rather delayed with delayed, you don't have a difference, even if you do it immediately and immediately. And finally, the implant type might have an influence on the marginal bone level. So this was the first glance on which kind of implant should we take. They concluded that with the immediate protocol, we have minimal crestal bone loss and a high survival rate. Next study of Malo and co-workers from 2015. They treated more than 500, almost 600 single-tooth implants with immediate loading and looked at 5 and 10-year follow-up. Although they had a high dropout rate, they had over 5 years more than 95% of survival and the same over 10 years. The marginal bone level was in the end of the study 1.75 millimeters, which again is acceptable. They only had a large variety of mechanical complications, which is the prosthodontic workflow. And finally, we are living in the world or in the century of peri-implantitis, which is a completely other kind of lecture. And also they concluded it's a viable and safe treatment option for maxilla and mandible. In the next study, you can see, which is very new, a systematic review over 10 years, where they just looked at survival rates which are minimum 5 years old. So they could find 34 studies with more than 5,000 implants. And the cumulated survival rate was, again, far over 95%, with the differentiation that the mandible is better than the maxilla. The marginal bone level also had a large variety, but nevertheless exceeding 2 millimeters. So also they concluded a very good long-term predictability and success rate. Looking at the maxilla only, the study of Toljanik shows 51 patients with 300 implants in immediate loading after 6 months with the final crowns, only edentulous maxillas, no augmentation, and they made a follow-up up to 5 years. You see the dropout was 1/4 of implants, which is very high, we have to say, but the 5-year survival rate with 93% is quite acceptable because it's only maxilla. The marginal bone level, you see, without any augmentation is less than 1 millimeter. So this also just gives a good sensor to edentulous maxilla. Looking at removable immediately loaded implants, there we have less data. And the only data with immediate loading and implants and removable prosthesis was done by Romanos and co-workers 2014 with 26 patients and 117 implants. 29 were immediately placed and 88 delayed placed, but all of them subprestally placed were immediate loaded with telescopic crown prosthesis, and those prostheses were not removed for 10 days. So the average loading period was almost 5 years, and the survival rate was 94%. Looking at the success rates, you see we have in 10 cases marginal bone level over 2 millimeters, and we had 7 failures. So this means removable prosthetics gives us a higher risk. But in the end, they concluded that immediate loading may be an alternative prosthetic solution for the edentulous maxilla. But I have to say, yes, we have a higher risk in the maxilla with removable dentures. And finally, we have to think about, why do we extract those teeth? Mostly we extract them because of infections. So let's have a look in infected sockets. And here we have one study from Anitua with 30 patients, immediate implant placement in the anterior maxilla into infected sockets with immediate loading. Looking at the results over 6 years, we have a survival of all implants. The success rate was 93%, which is quite high over 6 years. The marginal bone level 1.4 millimeters over 6 years. There were only 3 prosthetic complications concerning ceramic chippings. So finally, they can conclude that the infected socket itself is not a risk factor. Looking at all these data over the years, we find that 95% and more is a quite very good result for immediate implant concept. So the decision making for you means, when should we do immediate concept? Every time you have primary stability of an implant, of course. When you have no micro movements, we know that prosthetic blocking gives you more security. The minimal implant length should be 10 millimeters. The posterior maxilla still is a risk area. The precise planning of the position, especially in the blocked restorations, is crucial. You should do this more and more with a 3D navigation. So, ladies and gentlemen, we have 3 influenceable factors. One factor, of course, is the positioning of the implant. The second factor is the design of the implant. And the third factor is the prosthetic load of the implant. So, these 3 factors we should have a closer look at. Why? Because you and me, we can influence them. We can have more concept on putting all these positions together for more success. So let's start with the position. This is my content of today. Let's talk about implant positioning. Let's talk about the implant design. Which kind of implant is responsible? What do we need for immediate loading? And how do we load the implant? The position means where to place the implant shoulder concerning the prosthetic solution. You see on the very left picture, you see removable prosthesis anchorage. So here you can easily detect the implant shoulder visible. The implant shoulder is not placed very deep. The more you go to the posterior, you don't need to place the implant as deep. So you see this implant here is placed maximum 1.5 below gingival margin. This implant, which is the canine, already is placed 3 to 4 millimeters below the gingival margin. And the more you come to the front, the deeper you might place the implant shoulder according to the aesthetic demands. And that makes it necessary to think about the implant type. We have a tissue level implant. As you see, the Camlog first generation, which was a tissue level implant, it was made for a slight subgingival implant placement. Then we had the second generation of Camlog with the new cams and the platform switching concept, which is more or less a subtissue level implant, which can almost be placed on bony level. And with the CONELOG, you have a device or a fixture to place an implant even beyond bone level. So, looking at implant placement beyond bone level. What we want to see is that the bone level is in front of our implant shoulder, which means if we can end up with implants completely surrounded by bone, we have more stability of the soft tissue above. Looking at this picture, you see the bone is stable in front of the implant shoulder. We have bone higher than implant shoulder. And also looking between two implants or an implant and a tooth, you see that the implant and the abutment can be surrounded left and right by bone. Let's have a look at the first case. So this is a 51-year-old patient who lost a tooth several months earlier. We took an X-ray, and on the other side you see he already has an implant with less vestibular bone. And here we have, on the right side, we have already a bony resorption. So what we did is we placed the implant in a prosthetic right position. You see now the implant is placed with primary stability. Now you see we have enough torque control. We did an immediate impression taking with this transfer splint. And now we put some chlorhexidine gel into the implant, and now look here, I place a 2 millimeter healing abutment, although we close the implant. Now we do the bone augmentation with a membrane and the bone substitute. We close the membrane. A connective tissue graft, and then we close the full site. So this is how we ended up. And here you see the 2 millimeter healing abutment and the bony augmentation. In the meantime, we produce a long-term provisional on the final zirconia abutment. This is a zirconia abutment. It's not a provisional abutment. So after 6 months, we uncover the implant, we place the final abutment, and we place the long-term provisional. So this now is the long-term provisional directly after surgery. And again, you see, this is the luting base of the zirconia abutment, which it has a height of 1 millimeter, and you can still see this is the 2 millimeter augmentation we did around the implant. So we place the implant beyond bone. So this is the 4 months control, and you see after 4 months we have a nice stable hard and soft tissue. And after 9 months we only did a transfer cap impression, and this is the final crown now. So looking from occlusal view, you see that we could manage to keep the augmentation. And now looking at the black and white aesthetics, which is much more informative how we had bony reaction. And here you see that we still, after 1 year of occlusal loading, we still have bone on the shoulder of the implant. This was the 2 millimeter augmentation, and this is the 1 millimeter luting base. So this is how we started. and how we ended up. So this is now the 2-year control, 3 years after loading or after implant placement. And here you see the hard tissue 2.5 years after loading. And you can still see that we have a kind of hard tissue around implant shoulder. So the question is this bone? We don't know. We only know this is a hard tissue which stays stable around the implant shoulder and keeps the soft tissue around the crown. So this is the 4-year post-prosto and the 5-year loading result. And I think we ended up with a nice aesthetic appearance. So now let's have a look at the platform switching concept and the depth of implant shoulder. Normally we place an implant looking like this. This is a sub-tissue level implant. Here is implant shoulder beyond gingiva. This is a platform switched implant. By placing the same size of crown, you know you come out with a more narrow interface. And this might keep a hygienic problem because there is this small gap which has to be cleaned. If you now want to place a molar with a platform switching concept, you might end up with a hygienic trap. Now, how can we place a molar and platform switching? If you would place this implant, you might end up with a hygienic trap if you would come out like this. So you might use a more wider implant if you don't want to place it deeper, or you place the wider implant deeper. Now you can easily use the platform switching concept because now you have enough soft tissue thickness to go out. Or you use a sub-bone level implant like the CONELOG, just to place it deep enough to have no hygienic problem. And this you can easily also do if you have a sinus, because with the new implant we will see that we can end up with a nice immediate implant even in sinus grafts. So there is a difference in implant shoulder depth if you use the regular implant or if you use a sub-bone level implant. You should know that using a platform switching means also switching the shoulder of the implant. Now let's have a look at the implant itself. So here we have the largest changes in the last 5 to 10 years. The progress itself is that we need new outer surfaces of implants. And this is what you get with the new progressive line implants. The one side you see on the right, this is the CAMLOG progressive line, which is a sub-tissue, almost bone level implant, and the progressive line CONELOG, which is a bone level or even sub-bone level implant. Both are available with a well-known and well-established CONELOG and CAMLOG prosthetic platform. Just to give you a glance, what changed over the years? I'd like to show you only, for example, the CAMLOG implant, how there is the change. This is how they started with a cylinder line and an HA surface and a machined shoulder with a bevel. Then slowly they changed to the screw line, and then the new surface, and then the surface was made up to the shoulder, and this now is the progressive line on the very right side. So what's the difference in screw design? Looking at the CONELOG, you see the small threads with almost parallel implant design, and the progressive line is on the apical area from here to here. It's more conical, and from here to here it's almost parallel. So you have a more aggressive, more progressive cutting into the bone, and because of its tapered apex, you have much more stability even in soft and less bone. If you now ask, do I have to buy a complete new set of implant drills or even the box? No, you can use the same tube as you used already. The only thing, you need new final drills, and those final drills are marked with a black tip. All the rest still stays the same. The only difference is, looking at the progressive line implant, that the drill itself is redesigned, and you see in this picture that the drill is smaller than the threads. So in any case, you have a cutting design of the implant itself. And also there is another difference compared to the normal CAMLOG design. Even the shoulder of the implant has a thread design and is able to even be stable in the residual bone during a sinus graft. So you see, this is the outline of the drill. And the black area is the threading of the implant. And only this brings us to a higher primary stability, as you can see here, up to 250% higher primary stability. So now let's have a look at the indication for the progressive line. The indication, of course, is soft bone. And all we want to do, immediate implant, immediate restoration, immediate loading, and also immediate implant in the sinus lift. I'd like to show you one of the first cases I did with this implant. This is a lady who came in, 70 years old. She had an aspergillosis of her left sinus because of a root canal treatment after of the tooth 2-6. Here you see the tooth 2-6 with the insufficient root canal, and this is the remnant of the filling material, and she developed an aspergillosis. So the tooth was taken out, alieno loco, but you see the remnant of the root canal filling still was in, and the aspergillosis still was in. So what did we do? We opened this area, we just cut the facial wall of the sinus, and here you see this is the aspergillosis, which is very smelly, very infected. It is not painful at all, but it's very difficult to take it out in total. You have to cut it. It's very soft. Here you see it. Then you rinse the sinus. This is what I got out. You rinse the sinus after that with disinfection material. And now I'm suturing in the buccal bone plate again with resorbable sutures. So this was after doing surgery to the sinus. And then we told to the patient, because of the prognosis of this tooth still is questionable, she has a post inside, no root canal, and already a widened periodontal gap. So we decided also to take out this one and to place 2 implants. So we took it out, we placed a provisional bridge, then we did the planning for the sinus graft. And you see, in a normal concept, you would not place immediately an implant because it's less than 3 millimeters of residual bone. And with the progressive line, it was able to do sinus grafting and implant placement in one surgery. So we opened the sinus, here you see this is after releasing the Schneiderian membrane, and now we already placed the drilling for 2 implants. With the PRF technique, we augment the sinus, and now we place the implants. And you see, with only now 2 millimeters of residual bone, we already have primary stability. So now both implants are placed, we close with the membrane, and we suture the flap. And here you see, this is after implant placement and external sinus grafting. So now let's have a look at the different drilling protocols. And those drilling protocols, we have to concentrate on the bony quality, respectively the bony hardness. And I'd like to show you at an example of the CONELOG 3.8 millimeter progressive line, how we do the drilling in such cases. So if we have dense bone like D1 or D2, you see on the upper left side, we go the regular way with bone marking, pilot drill, and 2 form drills. And because of it's a very dense bone, we have a special dense bone drill, which then is used just to make the drilling hole a little wider. If this is still not enough, you might use this tap, and then you can place the implant. If you don't use it, look at this case. This is a 76-year-old male patient, and he lost, in the lower right side, he lost 2 teeth, and we wanted to place an implant in this area. So here you see, after socket preservation, we still can see a very hard bony consolidation. Now we do use the first pilot drill. I speed up this video a little more. So up to the 5 millimeter drill. This is the 5 millimeter form drill. Here you see, I just control the depth of drilling, only using the form drill. And now we place drilling holes for the membrane for lateral augmentation. And this now, look, this is the 5 millimeter Camlog with a machined shoulder Camlog progressive line implant, which we now put into the 5 millimeter drilling hole. Using the ratchet, now you see already now we have primary stability, we have more than 30 Newton centimeters. Now I block the ratchet and I did more insertion force. And now look what happens. If the insertion force is too high, if it is exceeding 100 Newton centimeters, now we are around 100. Look at the insertion post. there is a breaking point. So if the force is too high, it breaks. So on the other side, where we did also implant placement, you see we use the classic drills, and finally I use the tap. We use the dense bone drill and the tap. And by using the tap, you widen, for the progressive line, you widen the drilling hole as much as necessary for D1 bone. Now we use the progressive line 3.8, and you can see how easily it can be drilled in without fracture of the insertion post. So let's go ahead. Just the case, you see we did an implant placement without the dense bone drill. And you can put the implant without any fracture of the insertion post in the right position. But more interested is the soft bone. So here we do the so-called under drilling. So the under drilling means you use a more narrow drill and place the next higher implant. I'd like to show you one case on that. This lady presented with 2 teeth which we could not keep. The second premolar had an infection with a suppuration, and the first premolar had a deep pocket and also a root canal problem. Here you see the X-ray with the fistula. So we took out the premolar and we planned 2 implants. This we did with the immediate loading protocol and with a guide. So this was one of the first surgeries we did with the progressive line system. We presented the provisionals on final abutments, as you see here. So these are the complete digitally planned provisionals on the zirconia abutments. Just as a control, we did a 3D printing of a model. So this is the 3D printed model. Before we took out the first premolar, we produced 2 final abutments and a long-term provisional. On the palatal aspect, we produced those 2 notches because after bringing in the abutments, we can easily check if the rotational precision of the implant shoulder is in the right area just to do immediate loading. On the surgical approach, we now raise a flap after extracting the first premolar. Now we place the drilling guide. And we started with the immediate implant of the first premolar. . And then we drilled up to the sinus with a drilling guide for the second premolar. Now we use the osteotomes to do internal sinus graft. We fill the sinus with a bone substitute. Now we put back the drilling guide and we place the implants through the guide. And because we have a marking on the buccal side of the drilling guide, as you see here, this is the positioning index of one of the notches. So now we place both progressive line implants. We remove the insertion post. Now we place the final ceramic abutments. And we try in the long-term provisional. We prepare a pouch on the buccal side for a soft tissue substitute. We bring in a soft tissue substitute and then we cut off the keratinization of the flap. We split the flap and we suture it to both sides of the abutment. Finally, we close the screw channel with a PTFE material and we only put chlorhexidine gel into the provisional. So this is now directly after implant placement and immediate loading. On the palatal side, you can see that the rotational index is in the right position because on both crowns we have this little notch in the right position compared to the provisional. So here you see this is directly after implant placement. This is before and same day after. That's the X-ray control. This is now after 5 days. And this is the 3 months result, just to see what happens to hard and soft tissue. So with the progressive line, it is easily manageable to do immediate loading also in internal sinus grafts. Now finally, let's talk about the load. In single teeth, we do the extraction, then we place the drilling guide, and the drilling guide should just target on the palatal area. We use the drills according to the protocol I showed you. The final drill may be one drill below implant diameter. And then we place the implant through the drilling guide. We fill the gap between socket and implant with a non-resorbable material. We prepare for a soft tissue augmentation on the buccal side. And now you might place a connective tissue graft or even an artificial graft, as you may see here. Finally, we place the abutment and then immediately the long-term provisional. We place the long-term provisional first 7 days minimum only with the chlorhexidine gel, because then we don't have any cement remnants. Looking at the edentulous jaw, here we have immediate loading, which means we should think about the placement of the implants in a very strategic way. I think this lecture is not made for the planning of implants, much more for the planning of the loads. So we place our implants according to the three-dimensional SMOP planning I show you. So this is a 56-year-old patient where we did the implant placement in the lower jaw and in the upper jaw, but let's have a look at the upper jaw. We took out all teeth. Then she got 3 provisional implants to fix the guide. And then we made the strategic implant planning. And because of these 2 anterior implants have an angulated axis, we have to place angulated abutments. You can see this if you just show the prosthesis. So this is where we want to come out with the angulated abutments. This is planned into the guide, and this is the guide I get after planning. The same time we produce the long-term provisional, fully digital. This is what I got after digital planning, and now we place the progressive lines through the guide. We place the angulated abutments. Those 2 abutments are angulated. Then we place the conical sleeves. We try in the fixed provisional, which is now luted to the sleeves. And this is after screwing in. This is the control, and this is what you see after 1 year. Now we can go ahead with the final prosthesis. So I'm going a little more into the occlusion now, because we have to think about how we load the implants. This is more the prosthetics. We know that there are differences in biomechanics and tactile sensitivity. And responsible for this are the 4 control loops of chewing forces. There are 4 chewing forces: the perio loop, which goes out and into the muscle, then the TMG loop, then we have the lingual nerve loop, and we have a loop from muscle to muscle. So the most important one is the periodontium and endodontium. So if you lose this, your bite becomes much stronger. So we know there is another difference between implant and tooth. It's biomechanics. We know every implant has every tooth has a mobility, which is around 120 microns, and an intrudability, which is about 50 microns. An implant has a quite less mobility, which is because of the abutment screw. It's 5 to 10 microns. And an intrudability, which is maximum 5. So comparing the movement and the tactile sensitivity means that with implants we have higher chewing forces. We know that the regular chewing force is about 20 to 35 newtons. We know with a root canal treated tooth, it's 6 to 8 times higher. But we also know, with implants, it's up to 10 times higher. So now the prosthesis and also the crowns need to withstand, even if you take a removable, need to withstand those 10 times higher forces. This means we have to think about occlusal strategy in implant treatment. And in our clinic, we go this way. We use on the natural dentition side a shim-stock foil of 8 microns. And between implants, we use a 5 times higher foil. We call it a 30 to 50 micron occlusal clearance. You see this here. This is a tooth crown with 8 microns shim-stock. This is an implant crown. You can take out the shim-stock foil. And again, the tooth. If you now use 5 times shim-stock, it should stick. Because after cementation, you see that you will have a contact. And even after cementation, we try to have slightly less contacts to the implant crowns. What about edentulous cases? Here we have a bony load. And this bony load, you see, is in case of 50 newtons on a cantilever bridge, going down more than 3 times higher forces for the first implant. And then look at the distribution to the other implants. It's becoming less and less. And it's the same only if you use 4 implants. The implant neighboring the force gets the highest load. That's the reason, ladies and gentlemen, why some of us just tilt the implants to the end, not having any kind of cantilever. Finally, the last minutes, I'd like to show you how we do in our clinic now the modulation of the occlusal forces during immediate loading. We use the medical limitation. We know that during healing of endosseous implants, we start with a blood clot, then we have 3 osseointegration phases: the osseoconduction, the de novo bone formation, and then we have the bone remodeling. During this contact osteogenesis, we have a stability dip after roughly 4 weeks. And this stability goes up again during the next weeks. So this stability dip after 4 weeks is the hottest phase during immediate loading. We just can get rid of this by weakening the main chewing muscles. And the main chewing muscles is the masseter and the temporal muscle. We do this with the botulinum toxin, shortly called the Botox therapy. We know this from aesthetic medicine, but we can also use it in immediate loading cases. Look here. The scientific data shows Botox is pain reducing in TMD cases, but also Botox helps to reduce bruxism and also reduces the forces. So we can sustainably reduce maximum chewing forces up to 6 months. And we don't need it longer. We only need 6 months of reducing the chewing force. There is no influence on jaw opening. And even if you need long-term therapy, there are no side effects. We do this by therapeutic injections to the temporal and to the masseter muscle. We put 6 to 10 international units Botox in total into the temporal and up to 30 international units into the masseter muscle. I'd like to show you how we do this. The muscle should be contracted and then we put the injection very deep inside. A case where we did this, unfortunately it is not done with a progressive line, but we do this the same way using the progressive line in immediate loading. This patient came with already implants in the upper jaw, and we wanted to place implants also in the lower because the lower dentition is lost. So we planned 4 strategic implant positions. You see we have large bony defects, so it was very, very difficult to place the implants in a position where we have primary stability. And although we have implants in the upper jaw, we know we have higher chewing forces. So this was our drilling guide. And in cases of edentulous jaws, we need to fix the drilling guide very precisely because it's moving. For this, we use bone screws. In this drilling guide, we just placed 3 holes for bone screws just to screw in the drilling guide. The same time, we digitally produce the final, the abutments and, of course, the long-term provisional, which is then milled out of a resin material. So this is what we get directly before surgery. It's the drilling guide and the long-term provisional. And 3 weeks prior to surgery, we do the Botox injections. So with these Botox injections, I reduce the maximum chewing forces, even in patients with only implant restorations. And then we take out the teeth, we place the drilling guide, we place the implants, we place the abutments and the sleeves, we roughly close the flap, we put some bonder to the abutments, and now we try in the prosthesis. We lute it with a glue. We take it off. You see now how nicely it fits. And now it does not make any difference if you use the CONELOG, the Camlog, because from a prosthetic point of view, it is now the same. We screw in the long-term provisional and we check the bite, of course. And because of the Botox, the patient now has approximately only 50% of chewing force, so he doesn't loosen his implants over time. So this is how we started. This is how we ended up the same day. So the patient could get out with teeth again. Here you see the strategic implant placements. And that's the 12 weeks control. Now you see the unswelling of the soft tissue. So we can now take off the bridge after 12 weeks and we underline it with pink resin material. And after 1 year, we now know that the implants have a full osseointegration. Now we can go ahead with the final restoration. I'd like to conclude with 2 scientific data. One is a dissertation from the University of Freiburg, from Jurzig and co-workers. And I'd like to conclude with their summary. So, the prognosis of immediate loading using a modified drilling sequence enhances the primary stability of immediate loaded implants, even in soft bone. Which means we have to think about using the right drilling sequence, and with a progressive line implant, this is easily manageable. The immediate implant placement and the delayed implant placement have the same long-term results. So there is no difference at all. Splinting the implants seems to be important for the success. According to the shortened treatment time, they concluded that this is the comfort zone for the patients. And this is what we want to have in the end of the day. We want to make life easier for dentists and for patients. Looking at the second scientific data, it was a habilitation from Rostock, 2013, and also here the conclusions. The results show high success rates for immediate loaded implant, as I could show you also. The failure risk decreases after the first 6 months. So I would recommend, please not place final prosthesis before 6 months have gone. The only significant patient factor was the maxilla. In the maxilla we have lower stability, so we should place more implants and longer implants. The prosthetic concept is responsible for the success of the rehabilitation, which means think about how to load the implants. Even in immediate loading, think about Botox treatment. And the development of customized, immediately loadable and transgingival implants should be topic of future investigations. You see, this was mentioned 2013. Now we have 2020, and I think Camlog could bring us a nice implant which makes it possible to do immediate loading even in soft bone, even in less bone. Finally, Thomas Schiebler already was mentioning this. We can go much more into detail if you visit us to the course. The course is a very new concept, bringing hands-on and high-end clinical cases together. It's a course in Austria, Vienna. We do this as a 4-day event in a hotel and in the Anatomic Institute of the Med Uni Vienna. This is the hotel where we are in. It's a very nice grand hotel, a very old Vienna hotel, very typical. You can enjoy the Austrian feeling. And this is the Anatomic Institute, and there they have a special dissection room only for the students of this course. So it is a 4-day experience, and I'd like to show you the program. The first day is theory in soft and hard tissue management. The second day is, in the morning, microsurgical soft tissue management techniques. You learn the flap design, suturing techniques, and in the afternoon, we do the same things, the basics, to the hard tissue. The third day, you get a new specimen, and we do so-called bespoke surgery. You tell me what you want to do, and I'm going to show you, together with my colleague, how we would go ahead in such a case. And you can just follow step by step what we recommend you. In the afternoon, we can do the same. You tell us what you want to see during hard tissue augmentation. And after that, you do this to your specimen. Day 4 means in the morning, we talk about risk management, patient education, and then finally, you tell us what you want to see. You tell us if you want to see more complication cases, if you want to see early loading cases, immediate loading cases, and something else. Here you see this is the dissection room where you do the surgery. We have one big microscope where we can show you what we do on the screens. You see live what we do directly on the screen. Rudi Siemann, he is professor at the University of Vienna, and me, we are the directors of the course, and we together have in total about 15 to 20 participants, which means maximum 10 participants per instructor, which is a nice distribution. You see that we explain everything on the table. You can discuss it with us, and then we do the live surgery to the specimen, and you can follow us step by step with your specimen. The step-by-step learning includes even every stitch and cut. Here you see the groups over the past. We have very small groups, which makes learning extremely individual, and you can ask whatever you want in a small group. If you are a group only of one country, you can just invite a translator and you can have the full course in your language. So the course of 2020 already is fully booked, but maybe I see you 2021. Hope to see you soon. Now I'd like to say thank you, and I'd like to apologize for the inconvenience due to the virus in my computer. So I hope you could enjoy the lecture anyway. And if you have questions, feel free just to answer me now. Thank you very much. I hope to meet you in real life. Stay healthy, and I hope you are in your country, you are really in a good way to get rid of the virus and live long and prosper. Thank you very much.
Thank you very much, Dr. Beschnidt. It was a great lecture. So we have a few questions for you. I got on my iPad. So there is Eli's engine. This question is, for immediate implant loading, do you prefer Camlog or CONELOG?
I think it depends on if you have an immediate loading of a single tooth or if you have immediate loading of many teeth together, which means if you block teeth, if you want to place a bridge or a bar, I would rather go for the Camlog, because blocking implants is easier with a Camlog tube-in-tube connection compared to the CONELOG. The reason for that is that the cone itself has a so-called vertical misfit, and if you block implants with the CONELOG, it's more sophisticated. So if you want to have life easy, I would rather go with the Camlog.
Thank you for that. So you showed a case during the webinar with zirconia crown. Here's the question from Abdul Rahman Hamad. Is the zirconia abutment built on the tie base abutment?
No, yes, it's the titanium base. You can just order from Camlog, and this titanium base fits into the CAD/CAM milled base of the zirconia abutment, which is then luted to the base. Yes, it's not a full ceramic abutment.
Okay, then we have Mariam. He's asking criteria to use dental surgical guide for implantation. So when do you use or want to use a surgical guide?
Yeah. Honestly, the more experienced you are, the less you think of using a guide. But I now have experience with implants since 1995, and I still use guides, which means the guide gives you not more security, it gives you more precision if you want to immediately load. If you don't want to load immediately, you might just skip the guide, only if you feel more familiar to guiding your drill. But if you have some experience in placing implants, which you should have, placing an implant, you should get experience. You should not use a guide as a starter and think that using implant with a guide makes life more secure. The guide gives you the security that if you want to place immediately a crown, the crown is in the right position. But on the other hand, if you don't want to immediately load, you can just also skip the guide and place the implant with more view. But on the other hand, you have to open a flap to see. So if you decide not to open a flap and to immediately load, you should use the guide. If you want to open a flap, you want to see the bone, you don't need the guide.
Thank you. So the next one is from Imran Salem. In the sinus lift case, what is the minimum torque?
Yeah. For immediate loading or for immediate placement. So let me divide. The torque is only a kind of an indicator. Looking at the studies, we know that beyond 3 millimeters of residual bone, you normally should not place an implant because of stability of the implant. With the progressive line, and as I could show you, and I've got many cases now, you can place the implant also if you have less than 3 millimeters of residual bone. But with only 3 millimeters, you should not load, of course. But you feel that with 3 millimeters and the cutting threads of the shoulder of the implant, let me show you the picture again. I'd like to show you the picture of the implant. Could you, yeah. I'd like to show you this. Could you, yeah, please. Wait, I'm going more into detail now. Okay, here you see, because of these cutting edges here, we have primary stability of an implant, which means even if it is only 10 Newton centimeters, this implant can be placed because it's not loose, but it should not be loaded. If you want to load the implant immediately, so this is placing the implant. If you want to load the implant, you should have minimum 30 Newton centimeters of insertion torque. Did I answer the question? I hope so.
As we know, soft tissue biotype has significant importance, especially in aesthetic area. In your opinion, CTG is necessary in every case, or it depends on situation? For example, socket type, soft tissue type, etc.
So, you know, there are large varieties of answers now. The connective tissue graft or even a substitute you use to temporarily thicken soft tissue. You can't change the gingival biotype because the gingival biotype is genetically driven and you don't change genetics. We saw over years, if you thicken gingiva, most of those cases become thin again. There are, of course, cases with scar tissue which stay more stable, more thick, but you can't change a gingival biotype. The thing we do is during implant healing, we thicken the gingiva to allow much more tissue to heal around and to give a more close soft tissue collar around the abutment and the implant. And we know from the literature that in immediate loading cases, we have less recession of soft tissue using the connective tissue graft or a connective tissue support. So this means there are different opinions. I would use a connective tissue graft in every immediate loading case where it is aesthetically necessary.
Okay, thank you for that. Then another one from Vivek Mantala. Do the types of implant connection, for example, internal hex, internal cone, or external types, affect the long-term results on the full arch prosthesis?
Did I understand you right? We are only talking about edentulous cases?
It sounds like, yeah, result of the full arch prosthesis.
Looking at full arch prosthesis, we also have to divide in edentulous cases, which are long edentulous, and you just bring in a bridge with pink porcelain or even a hybrid prosthesis. Then I would say no, there is no difference at all. If you place full arch bridges into very nice soft tissue and you have to block the bridges, I would rather go for the Camlog with a tube in tube, because it's easier to do long span blocked or long span connected restorations. If you have single crowns, I don't care.
Okay, another long one, I need to read it. So it's from Kaka Metreveli. When there's an alveolar horizontal defect, please tell about possibilities of use CONELOG progressive implants when some buccal surface stays naked, parallel to horizontal augmentation with the GBR or NBR. What is your preferable way and loading time?
I think this has nothing to do with the progressive line or with another implant outline. It has to do with, first, primary stability. If you have a buccal defect, you have to divide, is this a fresh defect? Is it a fracture of the alveolar socket? Is it a defect because of periodontitis? Or is it a defect because of the extraction was done much earlier, so we have a so-called rich defect. So if it's an immediate implant and I have a lot of buccal plate, I think this is the easiest case. You place the implant in the prosthetic driven way, then you place a membrane, and then I would use a non-resorbable material, and I would augment this buccal side minimum 2 millimeters in thickness, minimum. And if you don't mind, I would show you a case on that.
Yes, that will be fine.
It's not done with a progressive line, but I don't care. It's the same surgical protocol.
So beside the questions, there are a lot of compliments for you, Dr. Beschnidt. Thank you for the great lecture. Everyone, yeah, so thank you.
I'm ready. I'm going through that very fast. You see, this is a lady, and it's easy to detect which tooth has to be extracted. We had a fracture of the 2-1. Here you see the fracture line. So we took out this, and now you see a complete loss of buccal bone plate. So we had a fracture of the bone plate, and we had the infection. Because due to the fracture of the tooth, we also had a resorption of the buccal bone plate. So what we did, and this case is very old, you see, I placed a 6 millimeter implant, and this is a tissue level implant. So today I would never do this anymore, but I was only using what we had and what we knew about implant placement. And you see, the complete buccal surface is free. I placed the membrane, and now I did a very large augmentation beyond that membrane of minimum 2 millimeters. It was rather 4 millimeters of thickness in front of the implant. and I closed it with a connective tissue graft. And after 6 months, today I would only wait 4 months. And after 6 months, we did impression taking, the all ceramic abutment and an all ceramic crown. So you could see how nicely we could stabilize the buccal bone. But I can't tell you if this became bone. It became a non-resorbing tissue. And this is what I want to have. I don't want to have any resorption. So I put in some material. And when I can get a primary stability, which is much easier to get with a progressive line, I can place an implant and I can stabilize buccal bone. And you see this case is very old, more than 10 years. I started 15 years ago, 20 years ago, I started with this kind of platform switching. It's a 6 millimeter implant and a 5 millimeter abutment. As you see here, we have nice, stable, soft tissue, nice, stable, hard tissue. But this is nothing if you don't know the long-term result. And here you see this is the 2 years. We still have enough tissue. Of course, today I would not place a 6 millimeter. I would place rather a 4.3 or a 5. And that's after 7 years when she lost the crown, it just fell out. So looking at the hard and soft tissue, you still have a stable tissue around. And this is now the 10-year control. So although we had a buccal defect, we have a stable tissue. I hope I could answer this.
Thank you, Dr. Beschnidt. So we had some more questions, but I think we are at the end of our session. For sure, there are a lot of courses we offer where we can answer these questions. Also, they can also do hands-on. So if you want to see our offer, just go to camlog.com, click on education, and you see all our courses. We also recorded this webinar, so you can see it on BioHorizons Camlog.com. So there are the recorded webinars and also the upcoming ones. Yes, Dr. Beschnidt.
Thank you very much for being with us online, and stay tuned. Bye.
It was a great pleasure. Thank you for your time, and goodbye. Thank you.